Welcome to another episode of Clot Conversations from Thrombosis Canada. I'm David Airdrie, Executive Director.
I'm Jamil Abdul-Rahman, hematologist from Toronto General Hospital.
We're here to provide you with updates on diagnosis and management of thrombosis, featuring interviews with authors of recent research publications and highlights of education programs from Thrombosis Canada. Thank you for joining us for this episode.
In this episode, we'll be discussing a recent paper published in the Journal of the American College of Cardiology entitled Direct Oral Anticoagulants versus Vitamin K Antagonists in Thrombotic Antiphospholipid Syndrome, Meta-Analysis of Randomized Controlled Trials, with co-authors Dr. Jean Connors and Dr. Benhood Bikdeli. Dr. Jean Connors is a hematologist attending at Brigham and Women's Hospital and Dana-Farber Cancer Institute, the medical director of the Anticoagulation Management Services, and the Hemostatic Antithrombotic Stewardship Program, and an associate professor of medicine at Harvard Medical School. And Dr. Benhood Bikdeli is a cardiologist, a vascular medicine specialist, and an investigator at Brigham and Women's Hospital, an instructor in medicine at Harvard Medical School, and an investigator at Yale Center for Outcomes Research and Evaluation. His research has been funded by the NIH, the AHA, the BWH, and others. Thank you for participating in our podcast today.
Thank you, Jamil and David. Benhood and I are delighted to be here to discuss our work. We're delighted to contribute to the Thrombosis Canada podcasts.
Can you give us a bit of background about antiphospholipid syndrome? What is it, and why might require different strategies for anticoagulation compared to other venous or arterial thrombosis?
Antiphospholipid syndrome is actually an autoimmune disorder in which people make antibodies to phospholipids. And the thing about the phospholipids is that they are critical for coagulation. And so these antibodies can be associated with developing thrombosis, both in the venous beds and the arterial beds. So deep vein thrombosis or heart attack and stroke. And what we know historically, when vitamin K antagonists, warfarin, Coumadin, and heparins were the only anticoagulants, that despite adequate anticoagulation with some of these drugs, patients with antiphospholipid syndrome would still have breakthrough or recurrent events. And so there's a lot of mystique about how to diagnose antiphospholipid syndrome and how to treat it. And the spectrum of expression of antiphospholipid syndrome that we see in people is highly variable. So it makes it a difficult clinical management condition.
So why did you feel it was necessary to conduct this systematic review and meta-analysis?
Well, as I alluded to, the management with vitamin K antagonists and heparin was sometimes not optimal for some patients, granted a small segment. But when the direct oral anticoagulants emerged on the scene about a decade or more ago, the ease of use of these agents is so far above the use of it, like an injectable low molecular weight heparin or fondaparinux, or the cumbersome management of warfarin with frequent blood tests and dose adjustments, and the real significant dietary and drug interactions with warfarin. So we looked at the data that are out there, and everybody is interested in whether DOAC have good efficacy and safety in the population of patients with antiphospholipid syndrome. And there were a lot of small trials that had been done. Some that had been randomized, even some that had different eligibility criteria involved. And I will let Benhood discuss in great detail with you as the mastermind and the architect of this study. He can speak to how we included, what the criteria were for including certain studies. But some of the trials were actually stopped early because warfarin was found to be superior to the direct oral anticoagulant used in the trials. But we're talking small numbers, 50 patients on warfarin versus 50 patients on a DOAC for the most part. And so there's really a strength in combining the data from these small individual studies into a meta-analysis and a systematic review.
Great. So can you tell us about the studies you found in your search and included in the systematic review?
Of course. First, let me also say hello. Thank you so much, David and Jamil, for having us and to be a part of this podcast for Thrombosis Canada. I think it's very important for different types of studies to have a thorough, robust set of questions ahead so that whenever we conduct the analyses, we know where we came from and where we are headed to how to interpret the results. And to that goal, we formed an international team of experts. I was fortunate to have Dr. Connors and several other experts in the team to guide us and lead us the way when we were thinking about the questions. So initially, we formed a study protocol, we registered it in Prospero, and in that process, we pre-specified that we would look not only in PubMed, but also Cochrane and a few other sources for completed randomized controlled trials of patients with thrombotic antiphospholipid syndrome who were randomized to one of the direct oral anticoagulants compared with vitamin K antagonists. But also as a separate objective, we also wanted to look at clinicaltrials.gov to see if there are any ongoing randomized trials in this space which could inform things for future. So in that process, we were able to identify 4 individual randomized controlled trials, 3 of which were related to rivaroxaban compared with warfarin, and the 4th one was comparing apixaban versus vitamin K antagonists.
Perfect. And I think the rivaroxaban studies were therapeutic dose rivaroxaban, but the apixaban might have been prophylactic dose. Is that right?
That is correct. So the rivaroxaban was tested at a dose of 20 milligram once daily. And I should say that for the apixaban study, the Astro APS, initially there was a plan to use the low intensity dose of 2.5 milligrams twice daily. But once they did some interim analyses, they decided to consider some additional exclusions to amend the protocol and also to use a higher intensity for the remainder of patients until the study was halted.
Okay. So what were your findings regarding arterial and venous thrombotic outcomes?
Thanks so much for the great question. So what we saw, first, we pre-specified that arterial thrombotic events would be one of the main outcomes of the study. Separately, venous thromboembolic events would be another important outcome that we look at. And then besides these 2, we looked at a host of other outcomes. For the 2 main outcomes that I mentioned, we noted that there was a marked, clinically relevant and statistically significant increase in the risk of subsequent arterial thrombotic events with vitamin K, with DOACs compared with vitamin K antagonists, whereas in fact, there was no significant difference in the risk of subsequent venous thromboembolic events.
Interesting. And then you mentioned you also looked at other outcomes like major bleeding, clinically relevant non-major bleeding, mortality. Can you tell us about those findings?
Of course. If I may, before I get to non-thrombotic outcomes, I should also admit that the majority of the signal for arterial thrombotic outcomes came off of stroke events with a nearly 10-fold increase in the odds. Essentially, all these stroke events in these 4 studies, granted still small, and even the pooled numbers are relatively small, but 10-fold increase in the odds with DOACs compared with vitamin K antagonists. But to your point, no difference in venous thromboembolic events, either DVT or PE, and similarly, no statistically significant difference for major bleeding events or even CR and MB. It still didn't reach statistical significance, and no difference in all-cause mortality either.
Okay. And you also did some subgroup analyses. You looked at triple positive versus non-triple positive, and also those with prior arterial thrombosis. Can you tell us why is that important, triple positive versus not triple positive? And what did you find?
Of course. So to take this important question, first, I want to allude to what I was sharing earlier about the importance of having a pre-specified study protocol. So I think one of the strengths of our collective work was with the group of experts, we were able to think of a few key subgroups where the results might be very informative. And we didn't know in detail to what level of specifications individual trials had reported the results per subgroups. But we were able, because we pre-specified only a few subgroups of interest, we were able to reach the PIs of those trials. And in certain occasions, we got study level unpublished results from them, which then lent support to meta-analysis. And those results, to make a long story short, showed consistency of the findings, whether or not there was triple positivity, whether or not we checked the findings in women versus men, and whether or not the initial qualifying event was an arterial thrombotic event or not. there is a lot of nuances to figure out, and I'd love to hear Dr. Connor's input about it as well. But I think with the limited data that we haven't seen effect modification across these subgroups. On a clinical basis, though, it's really more nuanced than one size fits all.
Yeah, no, I'm going to jump in here, Benhood, because again, great findings. And I think this is really significant. And I was delighted to be invited to be a part of this meta-analysis. So the studies that were included, the randomized studies, some of them had very different eligibility criteria in the individual studies, such that the TRAPS trial, you could only be triple positive, whereas another study, you could have any degree of, single, double, or triple. And so the strength of the subgroup analyses is that there was a rumor when, TRAPS trial came out and showed that warfarin prevented more arterial thrombotic events, recurrent events, than rivaroxaban. And as Benhood said, no matter what the qualifying thrombotic event was, whether it was venous or arterial, everybody who entered and had arterial events in the rivaroxaban arm, and again, many of them, the majority had venous. So that, that trial, people were willing to say, okay, stopped early, roughly 50 patients in each arm. We're not going to use DOAC in triple positive antiphospholipid syndrome. But people, were saying, well, what about single? What about double positive antiphospholipid syndrome? And that's where I think we really have, for the first time, somewhat more conclusive data in this meta-analysis that suggests that thinking it may not be correct, that we could use DOAC in even single positive antiphospholipid syndrome patients. So again, I think these findings do inform clinical practice.
Perfect. That's great. So overall, it was a very well done study. With any study, there's always limitations. What were some of the limitations from the findings in this review?
Another great question, and there are plenty, I would say, but probably the most important is a meta-analysis is usually as good as the source data would be. So in this case, we would have loved to see larger studies, ideally seeing each of the individual studies toward completion, and ideally to have had individual patient data to be able to pool and assess across many subgroups, not these. Ever since the results got published, I've received requests from friends and investigators to show the results by age subgroups, whether or not they received baseline aspirin, and many other questions. And I agree, all of them are important. The challenge for us was, if we were to expand on our request, we would have risked it to the extent that the PIs of trials wouldn't have time to share unpublished data on so many requested analyses.
And also, again, the numbers start to get so much smaller, right? I mean, already we're talking about a very limited number of randomized trials with low numbers assigned to each treatment. So that as we start to slice and dice the population, the strength or the significance of what we can say really diminishes.
So yeah, you mentioned the strength of the evidence. So you use the grade criteria to estimate how confident we can be in the findings of the study. So how confident can we be in the findings?
Thank you for this question. So according to grade criteria, I think the arterial thrombosis outcome that we assessed, we can be pretty confident. I think that was the outcome that we had more certainty about. But for other outcomes, the degree of our certainty is a little less. In part, again, because just the number of participants in each of the individual studies was fewer. And as such, even in pooled analysis, we can have less confidence about the robustness of the results. So in summary, I think for arterial thrombosis, there is fairly high certainty, but for either VT or bleeding outcomes, probably it's a moderate, but the best of what we know at the moment.
So what are the takeaway points here? How should we be anticoagulating those with thrombotic APS? And should triple positive and non-triple positive thrombotic APS patients be managed differently?
Well, I think that it's clear that the triple positive patients are at high risk for recurrent arterial events, no matter what their primary qualifying event was. As Benhood said, it's an interesting finding that there's such a strength for the arterial, whereas the recurrent VTE sort of is neutral. And again, it simply may be that the DOACs appear not to be as good at preventing arterial thromboses as vitamin K antagonists. And that to me is concerning because we had fewer people in the single and double positive cohorts. And I would be reluctant, say, to have a patient with a high titer, anticoagulipin or beta-2 glycoprotein 1 antibody and a significant PE be managed on a DOAC, even if, they were single positive. So I don't know, Benhood, if you want to discuss your approach to managing these patients, but I think location of the clot on the venous side is less compelling than the type of positivity for antiphospholipid syndrome. I still have some anxiety. So I don't know how you approach that, Benhood.
Thank you so much, Jean. I very much agree. Overall, even before this study came, I was always kind of stressed to use DOACs for people with thrombotic APS. Obviously, I was trying to avoid it for triple positive, but for others, it was an open question to me. After the results of this study, even when I have patients who are single positive, the very least that I do is I share the data and I'll stay honest with them. Here is the situation. Now, there are several other considerations. Some of the patients are absolutely disagreeing with taking a vitamin K antagonist or have other concerns. I would factor them in, but all in all, I agree. The one question that I have in mind, which I would love for us as a community of investigators to answer in future, is why is it that in APS we have the excess in arterial thrombosis? Because, for example, for stroke prevention and atrial fibrillation, maybe it's a different mechanism. It's like low flow in the left atrium, and DOACs are doing just fine. But in this situation, is it that they're so inflamed and so susceptible that we need something more potent, probably vitamin K antagonist? That's a guess, but it's a question that's haunting me.
Well, I think that's an excellent question, Benhood, and this work opens the door and highlights areas of remaining uncertainty that certainly need to be investigated further. And I do share your question about what is it about the arterial side or the arterial vasculature that's different compared to the venous with antiphospholipid syndrome. I am not convinced. Yes, VKA or warfarin are significantly better, but I have still seen in practice many patients get recurrent arterial events despite adequate intensity of warfarin with no gaps in excellent TTRs. And so I think whether it's just more intense warfarin or warfarin is, knocks off, say, 4 targets, 2, 7, 9, and 10, whereas the DOACs that most of us are using, the 10A inhibitors, knock off just 1, and therefore we have a stronger effect with warfarin. I think we may want to investigate, as Benhood said, that maybe some sort of inflammatory process contributes to this, vascular endothelial disruption. So we may need multiple strategies in addition to anticoagulation to really keep our patients safe from recurrent events.
Great, thank you. Is there anything else you'd like to add before we finish up today?
I look forward to seeing further data from Benhood, and I think the world is primed. We have a number of important research questions that have come up as a result of this that now need to be investigated, and I look forward to seeing those results.
Thank you so much. And I'd say it's been an honor to be with you and being a student of Jean's. And I look forward to continued learning and knowledge generation so that we can do better care for our patients.
Well, thank you both. It's been a real pleasure talking with you today, and thank you for joining us on our podcast. We really appreciate it. Thank you for listening to Clot Conversations from Thrombosis Canada. We welcome your comments, questions, and suggestions on the podcast. If you have any recommendations for future podcasts, please send them to us at info@thrombosiscanada.ca. And please subscribe to this podcast so that you are notified about the release of new episodes. And don't forget to check our website for education programs, clinical tools, and guides. Also, please consider donating to Thrombosis Canada to support our ongoing efforts to reduce morbidity and mortality due to thrombosis.